Good morning, everybody. Thanks for coming and attending our master class presentation. Just make some quick introductions. I'm Adam Aronson. I'm the CEO of a company called Arrowsight. We do remote video auditing. I'm going to give you kind of an explanation of what exactly that is, how we do it in the United States and in a number of different industries, including healthcare. And then you're going to hear from one of our clients from the United States. We've got Dr. Bruce Farber, who is the Chief of Infectious Diseases at North Shore LIJ System. It's a group of hospitals in New York State. And his colleague, Donna Armelino, who is the Director of Infection Control. So at a very high level, what we do is we have camera systems that we put into all sorts of different types of businesses, from food manufacturing to fast food restaurants, all sorts of security applications. And we also work in healthcare. And what you see here is a concept of putting cameras in ICUs, for example, to monitor for hand hygiene, ICUs for critical care applications, and surgery. And what we're doing is the video that's being recorded is being streamed back on a sample basis to our call centers. And we have several call centers overseas as well as one in the United States. And we monitor for whatever it is that our clients want us to observe for. So what you're going to hear from the folks from North Shore is about a published study that they did around hand hygiene compliance in an intensive care unit, monitoring kind of what the real rates of performance were without any feedback, and then giving feedback, which would look something like this. These are electronic scoreboards that get put on the walls of the wards. And in this case, they had set a rule that said if compliance is over 90%, they want to see a positive message, great shift. Weekly rates and other data gets posted to the boards as well. And then in addition to the real-time feedback, there's daily and weekly reports that include statistical summaries as well as links to the video that we examine on behalf of the client. So this is really high level. And what I'm going to do is just give you a little background about how it is that we came to work in the healthcare industry and how we are now trying to break into the UK system and the rest of Europe. So we didn't start in healthcare. We actually started in food manufacturing, and specifically the meat industry. Their concerns around food safety, as you can imagine, are pretty significant, and as well as efficiencies. So we really focus in the area of food safety, as an example in the beef industry, on making sure that the food safety practices, specifically sanitation of knives and cutters and hands, are being performed very judiciously while workers are taking the hides off of cattle. So the bacteria that's on the hides, if it comes into contact with the meat, it's very hard to wash it out, to clean it, to protect against E. coli and salmonella contamination. And so our services, just to give you an idea of the scope of work that we do, about 50% of the U.S. beef supply uses our technology and our services. And one company, which is called JBS, which is the largest beef company in the world, and they make up about 20% of the U.S. Beef supply. These guys used us for exactly that type of auditing, and what they sort of thought was going on around these practices and their 8 large facilities, they thought that this was a 100% perfect compliance. They had records, and this was all done by direct observation, people walking around with clipboards or PDAs, taking down performance metrics, but the workers knew that they were being measured. So it's such an important task that they knew that they needed to do a great job, at the very least when they were being observed. In reality, as we started to collect data and show them without any feedback what their real scores were, they weren't at 100%, they were 96%. Sounds like a pretty good number, but in that business, if you're not over 99%, you get recalls. And recalls are financially devastating, as well as obviously for public health reasons, very, very bad as well. So as they started to allow us to provide the feedback to the plants, what everybody was kind of shocked about was that 96% actually represented some workers, obviously not a lot, but some that were as low as 25%. And every worker comes into contact in that business with every single carcass. They work on different parts of the carcass, taking that hide off. So what they did in terms of taking this information and making use of it is they got their compliance rate in aggregate over 99.7%, and as a result of that, their E. coli rates dropped by about 60%. So that's kind of where we've been for quite some time. I've been doing a lot of food safety work. We do a lot of efficiency work as well. But back in maybe, I guess, 2004, 2005, I started to show my father some of this information. And my dad is a vice chair of quality at the Beth Israel Deaconess Hospital in Boston, which is one of the Harvard hospitals, and he's a professor at Harvard Medical School. And he looked at me and he said, you know, this work on hygiene and safety, you've got to bring it into the health system. The problems in health are much worse than they are in food. And he sort of said I had a social responsibility. I had to do it. It wasn't really an option. So I said, okay, I'll try, but you know, I don't know anybody besides you in healthcare, so give me some intros. And he did, and nobody would take free systems. I mean, we were like, here, take some free cameras, we'll give you some services, we'll try to do this. Nobody would do this. This was back in 2005, 2006. So I went back to him and I said, I tried, you know, couldn't do it, but I'm going to go back to my day job. And within a year of that, both my mother and my sister got hospital-acquired infections. And I had never experienced this. So it was, you know, they were very severe, and it was a big kind of shakeup in our family. So I got kind of reinvigorated and focused on it. And I went back to the drawing board, and instead of trying to get, you know, big teaching hospitals, I went to a small surgery center in Macon, Georgia. We did a pilot for a couple of years on hand hygiene, and we're able to demonstrate, you know, hand washing rates at a baseline were under 30%. We got them to 90%, sustained it. And then along the way in 2007, I met the folks at North Shore LIJ. And Dr. Farber and Donna said, you know what, we've been thinking about this. You know, didn't really know where to go with it, you know, using cameras to monitor for hand hygiene. So we all said, let's do a study. Let's do a comprehensive study. And that's what you're going to hear about after I'm done. But basically, to kind of fast forward to, you know, why are we here in London today? In the fall of last year, a major article was published in Clinical Infectious Diseases by North Shore about the use of our program. And that got a lot of press, the New York Times, a lot of TV, Bloomberg News. And the folks at GovToday, the folks running this conference, contacted me and said, you know, you need to really get to know what's going on in England. There's a lot of progressive work already being done here. We think this might be a good place to come and do it. So this is late fall, you know, December, January, I came over for one meeting. I said, you know, we need some introductions to some trust to see if anybody would like to do this. And through their network, they did make a number of introductions. And I mean, we work with McDonald's and Cargill, really big companies, and the sales cycles, just to get people to trial things, it can be a year, 2, 3 years sometimes. And I'm happy to report to you guys that 2 of the 7 trusts that we've been in discussions with, one which is a showcase trust, have agreed to do trials. And so, you know, sometime this year you'll be hearing more about it in the UK. We're probably going to take, these are trusts up in the north. We're probably going to take on at least 1 or 2 more trials down here in the London area. But it's been pretty terrific. Before I show you some slides on how some of these applications work, it's worth noting that what you're going to see from folks in the U.S. around hand hygiene, the way that you guys do hand hygiene is very different. So we're following the U.S. the CDC guidelines, which the ICUs have single rooms. And so if you walk into or exit a room, you need to wash your hands. And it's not the WHO guidelines, the 5 moments of hand hygiene. It's very binary, a fairly simple set of rules. So my first meeting was with one of the trusts up in the north, and you know, I had my meeting and my presentation, and I showed a video, and everyone sort of was shaking their head. And they said, you just have no idea what you're dealing with here. So this very nice lady named Margaret said, well, why don't you come with me and let me show you what's going on. So she opens the doors to one of the ICUs, and I see the open bay. So in the U.S., I use motion sensors to know whether somebody came into or left a room. I'd never dealt with an open bay environment, and I was like, oh my God, I've flown all the way here. How did I not know this? So I had to really go back to the drawing board, and what you're going to see is kind of how we have designed a system using the existing tools that we have to address this. And we'll start with hand washing, and then we'll get into some critical care and some operating theater applications. So we own some patents on using still pictures. So again, just take a step back. There's cameras in the ICUs. There'll be a camera on every single patient, like one camera per patient. And we have people in call centers looking at the video on a sampled basis. So step one would be using these still pictures as kind of a search tool to see circumstances where a patient who was alone for minute 1, minute 2, minute 3, and then minute 4, there would be a caregiver at the bedside. That to me is the equivalent of a motion sensor. And using the WHO guidelines, that would be one of the moments to monitor for hand hygiene. And so this is kind of our first step. This takes the place of having motion sensors in rooms and allows for us to get after hand hygiene monitoring in an open bay ward. So then number 2 here would be the second step. Now that I know what time somebody was at the bedside, we'll go and monitor to make sure they wash their hands. That's all done in the call center, and then feedback is going to go back to those LED boards, and so this would be real-time feedback so people understand kind of in real time how they're performing as a team. And then there are daily and weekly reports, as I described a little earlier. So that's kind of the open bay. There are isolation rooms. So for isolation rooms, the only difference would be we would use a motion sensor to let us kind of shortcut to events where somebody was in the room, but then after that, we have to do the exact same thing we do in the open bays because, again, the 5 moments of hand hygiene are requiring knowing exactly when a patient is being approached by a caregiver. So nothing terribly different here. And then one of the trusts said, we also have rules just entering the ICU itself. So we want to make sure that people wash their hands entering and exiting the ICU ward to begin with. And again, we use a motion sensor, and this is almost exactly like we do it in the U.S. So that's the hand hygiene piece. There are also a number of critical care procedures that we can monitor for strictly using video. And I think the one that I'll focus on, because it is quite a newsworthy topic from what I'm seeing over here, is pressure ulcers. So being able to monitor, again, using those still pictures, if the patient's sort of in position 1, the same position for 2 hours, and then they're in a second position, that's good. That means that they were turned. So if you saw for many hours, 4, 5, 6 hours, that the patient hadn't changed the position, then you would maybe need to give an alert to the unit. So there's some great applications. I won't kind of go through every single one of them, but the general idea is that there's certain things that we can visualize that we think could add a lot of value here as well. And it's quite different in the U.S. because they're using electronic medical records. So I even know, like if suctioning was done for a ventilated patient, we'll know exactly when that happened. So we can go and look at that video. So here it's a little bit different because you're not using the electronic medical records. So we have to kind of make do with what we've got. In the operating theater, there are sort of 2 buckets of services. One is scrubbing technique, and basically making sure they're doing the right steps for the right amount of time. Another really important one is the timeouts. So to help avoid wrong site surgery, again using the stills, if I know that a case started and the hospital tells me within 15 minutes prior to a first incision, that there should have been a timeout, we can quickly, using these patented search tools that we have, we can go find those events. And in the case of a timeout, it's not just making sure that it happened, it's making sure that the right number of people were there and that nobody was multitasking, nobody was on a phone or PDA, just basically observing in full motion video to make sure that people seem like they're paying attention. Then there's throughputs. And so in the U.S., most of the financial wherewithal of these hospitals comes from the surgery department. And so being able to process more cases per day is a very high priority. And it's simple stuff like, did they start the first case on time? That's, just as a very simple example. Another example, and this is more of a real-time example, is when the room is finished being cleaned, does the surgery department even know about it? If you have a large hospital that might have 20 operating rooms or operating theaters, we are, offering basically real-time services to alert the surgery department, hey, room number 3 is coming to the end of its cleaning cycle. You can stage that next case to come in. So it basically looks a lot like what we do for these, food companies and the restaurants. We help these guys, a whole other part of our business is helping them move faster. So for the McDonald's restaurants, for example, we've been able to get them to move their customer lines 30% faster. So we think that a lot of that would apply here. Not so much making surgeons work faster. That's not at all the focus. It's more of room changeovers. There are also more analytical things that you can do in the operating theater. So you can sort of break it into a group of different segments and sort of measure to see if there's a lot of variance by different teams of workers, different teams of nurses or physicians, et cetera. And again, using sort of the stuff we do in our other businesses, help people understand sort of the clouds part, and you understand kind of your most efficient teams and your least efficient teams, and you can use it as a training tool to get everybody to be more efficient in general. And this is just a visual of looking at one of the process segments. So how do we do all this and not make everybody revolt? How do we do it so, nurses and doctors don't, fight against it? How do we do it and protect patient privacy? These are the questions that I would expect to hear in a room like this. So I'll just run through these very quickly. Patient privacy is basically done through consent. If a patient doesn't want to be on video, there's technical tools that immediately allow for us to disable that camera. So patients aren't forced into doing this. We didn't have to do consent in the U.S. because we didn't have to have cameras on the patients. We only had them on the doorways and the sinks. But prior to that, when we did the surgery center, every patient had to consent. And out of 2.5 years of doing that work, thousands of cases, I think less than a dozen people decided not to be, given the extra safety measures. So worker privacy, it's all about disclosure. You can't just put these things in. You need to really talk to people and engage them and encourage them that this is a tool to measure excellence. And it's the first time that objective third-party data, which really shows true performance, because when you're standing there with internal, conventional methods of, taking down scores, the behavior changes. So you don't necessarily know for sure who your great and your not so great workers are. This kind of makes it real. And then you've got liability risks. So you've got all this video. What if you had an adverse event in a surgical case? What if an adverse event happened in an ICU? Because of patient privacy, we have to treat that video with the utmost security. And so we've set up technical facilities which essentially, as soon as we're done looking at the video is immediately purged. So there's no permanently stored video to go look at as just a business process. It has to be that way in order to protect the patient privacy, because that's the top priority. And then IT. So we always wind up having a conversation with the IT department about how we're going to get into their network and see video over their network. We've never failed at it, but it's another part of the puzzle. And in summary, for us with the remote video auditing services, you tend to get very fast results. Donna will talk about how quickly they were able to get baseline rates that were quite low to over 80%, 4 weeks. We see that in almost every industry. It's very kind of a fast uptake. Much more importantly, you can sustain it. And that's the problem with most new technologies, programs, posters, whatever you do. You have a burst of compliance and then it kind of pulls back because there's other priorities. This sticks around. We never leave. It's an ongoing service. And as a business person, if I see your scores slipping, I call you. I badger you, because if your scores really slip, you're going to fire me. So it's a pretty real service, and it's very accountable. And the final piece, and one of the earlier speakers talked about, is it cost effective? Can we even afford this? There's cameras everywhere. There's services. What does this look like? And it's pretty affordable. It's I think in the UK, sort of translated into pounds, it'll probably be about £1,000 per camera. It would be the cost to install. That's a one-time expense. And then for sort of a bundle of the hand hygiene and the critical care applications, it'll probably be under 2,000 pounds a month per ward. Most of what we're focusing on is high risk. So the two trusts that we're working with, hematology, renal surgery, renal medicine, one ICU, operating theater. It's your kind of main attraction, high-risk patients or high-risk activities. So with that, I will transition to Donna, and at the end, we'll be taking questions. And we also have a booth out there. If you don't get your questions in and want to just talk to me on the side, we're out there. Thank you.
Just want to thank you for inviting me to this beautiful country. It's my first time here, and I will be back. Just so you're aware, Adam does come from Arrowsight. Dr. Farber and I represent the North Shore LIJ Health System. We have no interest in his company. I do not hold any stock. I may talk to him frequently, but really it's a mutual working relationship to achieve increased hand hygiene. That's the relationship. So the sales pitch part is over. This is going to go through my experience, the experience we had with this technology within a hospital setting. It's a relatively large hospital. It's 850 beds. I've been to some of your hospitals here, 1,100 beds. I mean, they're massive. What I find interesting as I sat through the presentations this morning, US, UK, we have all the same challenges. Really no difference. I do want to commend you on your decreased rates, especially with the MRSA bacteremia. I understand how much work it takes. It does take years. It's not something that's going to happen overnight, and you've done a wonderful job at that. And I think we, on the state side, need to, share some of the experiences and what we've done in place and put in place to decrease infections. So I'm going to go through this. Everyone should be able to get access to clinical infectious diseases. So if you do have interest and you want to, go through the details of how we implemented and different aspects of the study, it is online. I will give you my card if you have any particular questions. We're also available, to answer questions. The problem, well, this has been centuries. How do we solve, hand hygiene? We have adults, they're professionals, there's different levels of education, and we still can't get basics completed at the time it needs to be done. We have the challenges, you have the same challenges, and we continue to work on this. So the project aim was, to look at continuous third-party remote video auditing with feedback on hand hygiene upon entry and exit. I know we have different guidelines. We use the CDC guidelines. You use the WHO guidelines. We ended up selecting only entry and exit of the room because it was new technology. People were not accustomed to cameras in a hospital setting. We wanted to avoid having the cameras on the patient, so the cameras were looking at the hand hygiene sinks as well as the alcohol-based hand gel. It was kind of safe. So that was our approach to this. Here, we're going to be doing it a little differently. We're also looking at North Shore doing it a little differently also and putting the cameras on patients. We just have to build the rules because you want to make sure you adhere to the dignity and respect issues and privacy issues of the patients. But with many other areas, cameras have been shown to be beneficial. And we're hoping that the cameras could also increase the safety within our hospitals. Project setting, it is a hospital that employs over 6,000 healthcare workers, over 3,000 physicians. There's 812 beds on our C of N at this point. There are probably more than 812 beds. But the project was done in a 17-bed ICU. Now, with anything that's innovative and different, you always have to get individuals that are willing to participate. You're never going to have any kind of success if you don't have the prime individuals within that area willing to participate. So out of 7 ICUs within this one particular hospital, we have a physician-nurse team that'll do anything. They'll try anything. So we approached, various physicians as well as nurses, and of course the same team from the medical intensive care unit said, we'll do it. The other ones were a little hesitant. What are we going to do with cameras? So we went with the team that was willing to work with us. And that's how we ended up in the 17-bed medical intensive care unit. If you're really going to do something like this, you want to look at your highest risk ICU. This was probably not our highest risk ICU with infections, so it would have been ideal one of the others, but because of willingness to participate, it ended up being this particular unit that we selected. So the timeline went, we started in February after we had leadership on board, meaning individuals from the administrative suite, as well as the CEO of the health system, because we wanted to make sure that everyone was on board with this. We then went to various staff meetings because we wanted the staff to understand what was happening, and we wanted to get a better sense on what their feelings were about this. So we went to various staff meetings, and repeatedly what came up was, is this going to be used as a one-on-one? Is it going to be used for disciplinary action? And our whole goal was to increase hand hygiene. It was not to get you. So, the promise to them was aggregate information. We're going to use this aggregate data. There is no one-on-one, and use the information to increase the aggregate hand hygiene, using the whole team approach to get the rates up. So we did that in February. Cameras were installed in March. We started to just look at baseline hand hygiene with the rules that we developed to measure hand hygiene in June. We did initially want to do about 6 months of baseline, but as you know, once you have information, you have to make a decision. Do we act on it or do we wait? So we decided to act on it, and you'll see why we decided to act on it. So then in October, we started to feed back the information to the staff as well as the managers, and to date, March 2012, we still have cameras in this ICU. Now, how does it work? As mentioned, you have door motion detectors, so you walk in the room, the video camera starts to record, the information is held on a digital video recorder. External auditors from Arrowsight retrieve that information electronically. They view the information. They'll then identify pass, fail, or a discarded event. And then that information that gets entered into the electronic system goes right back to the LED boards that are in the ICU. So within 10 minutes, you will have that information continuously updated, so you have up-to-minute information. This is just a diagram of the unit. We do not have all private rooms. Majority of them are private rooms. We do have 2 4-bedded rooms. But from what we had seen, 2 days ago, it looks like they're mostly ward-type settings here, I guess, with, movement and construction with private rooms. So we don't have the ideal either, okay? It's a combination of both. But you'll see that the red dots represent the motion detectors for the doorway, and then the various cameras that are both in the hallway and also within the patient rooms. The ones in the patient rooms will visualize the hand washing sink as well as the alcohol-based hand gel that's in the room. And then in the hallway, we have the gel outside the room near the medication carts and various strategic places throughout the unit. So we needed to have it in both locations. So when we came down to how do we measure this, we decided, like I say, as you walked in the room and as you exited the room. So if you walk into a room and you perform hand hygiene within 10 seconds and you were in that room for 60 seconds, it'll be looked at and evaluated as a pass or fail. If you did not wash your hands in 10 seconds and you did it at 11 seconds, it was a fail. I mean, you have to make a cutoff. When you develop measurement, it has to be, these are the rules, so you did it at 10.5 seconds, it's a fail. Has to be within that time frame. Just to make sure that the auditing is done correctly, Adam's company has a process where they will review the footage and make sure that the pass or fail is done correctly. At the beginning, I was looking at some of the footage just to make sure his auditors and what I was seeing, and both of us were coming up with the same, end result. Not that I had any doubt, But it was something new, and if someone asked me, did you ever look to make sure that there was accuracy, I would have to say, the truth. So that's why we looked at it, or I looked at it at the beginning. Inclusion, we decided here is really just the nursing staff, which would be the nursing assistants, as well as the physicians, the residents, and the medical students that came through the unit. We did not do environmental services. We did not do dietary, engineering staff. We only wanted to look at those individuals that would have contact with the patients. How did we distinguish these individuals? Everyone has uniforms. Nursing, has a Malibu blue. The residents also a shade of blue. Our physicians, at least the attending physicians, lab coats, street clothes. And then the other staff that we excluded also had very distinct uniforms. So when Adam looked, they were looking at the video, they were able to distinguish, yes, it's an included person, and then they would proceed to the pass or fail. So a pass would be, exhibited here, where someone would go to the alcohol-based hand gel, solution would be dispensed, and they would rub their hands. This study did not look at quality. We only looked at whether or not they went to the sink and the water went on, and if they went to the alcohol-based hand solution and solution was dispensed. We did not look at the quality. The big question was, can this work? Can it change behavior? The 2 LED boards, they're right there in the hallway. Patients could see them, visitors could see them, any healthcare worker could see them. And yes, we have had visitors question, what are these boards? So the last thing you want to do, explain to a family member, when rates are 60% or less, what the boards are representing. So that's another motivator to try to keep the rates up, because here you're going to have someone question what you're doing. And if you can't do this right, how could you deliver care in an ICU right? And the messages could be changed to anything you want. I mean, this is what we selected. At one point, we used to have rooms on there. We used to break down the physicians and the nurses because the physicians were less. So that was kind of, an incentive to try to bring the numbers up. And then once the numbers were close, we did merge them. Emails go out to managers as well as myself, Dr. Farber. So my BlackBerry, I could tell you what the units are doing now. I get messages twice a day. I'm not the prime person that reacts to the numbers. It's the managers in the ICU and the physicians that are expected to keep the numbers up. Every now and then, I see the numbers dip, and I could say, my rule is if I see it twice below 80, either I'm calling or I'm going. So it's just another, way to try to motivate people to keep the numbers up. If people know what the expectation is, then they will try to adhere to those expectations. Now, the weekly reports, also, you could create weekly reports that summarize what's occurred in the week, the month. You could break it down by other healthcare workers, attending physicians. You could look at it by shifts. When we looked at the information, we did look at, weekends versus days. There was really no difference. We did look at shifts. Actually, evenings had a higher rate of compliance versus the day shift. And that's probably because the activity during the day is higher. You have more consultants coming in, and it's maybe a little bit harder to police because of the activity. Now, we had 3 distinct questions. What are the rates of hand hygiene compliance using third-party remote video auditing with no feedback? Then the other one is with continuous feedback. And then the big question, can technology increase hand hygiene and sustain it? So here's the answer. The rates with no feedback were less than 6%, relatively low. Keep in mind, I have gold standard. I have human observers, like probably most of you do, going out there and looking at hand hygiene, and I'd get 60%, and I'd get 80%, nowhere near what we're reporting here. Part of it has to do with the rules. The staff did not know the rules. They did not realize there was a 10-second rule. So the rates were higher than 6%, but I can't imagine them being any higher than 30%. So needless to say, human observation, you're probably getting a lot higher rates than really what's happening 24 hours, 7. Because keep in mind, very rarely do we come in on weekends to do this, and the night shift doesn't get done. So once we started feeding back the information to staff and the managers, and they knew what their rates were, it took less than a month to get to above 80%. So expectation was given, feedback to the staff was given, they knew where they were, they knew where they had to go to, and they were able to achieve it. So this is just a way of getting information and providing it so people then could achieve what they're expected to do. And the rates are this high. We're having a little trouble getting past 90. So with that, we have to figure out. We have to figure out what's the issues of getting above 90 and consistently staying above 90. 85, 88, they're able to accomplish. We have to figure out from an environmental standpoint, what's happening, to get these rates to where we want them to be. Well, we thought this was such a great idea, and just so you know, the other units that first told us no, they want it now. So we ended up moving it into a second unit, and they happen to be 2 adjacent units. They're mirror images of one another. We even placed the LED board, so if you stand in the hallway, you could see what SIC is doing and what MIC is doing. We did that on purpose, just for that natural competition. So it's an 18-bed surgical intensive care unit. Timeline, we only looked at about 1 month of baseline, and then we started giving feedback. So the questions were very similar to the first one. Can this change? What was interesting when we looked at and we compared MICU's baseline to SICU's baseline is SICU was higher. Some of they knew the rules, so knowing the rules is not quite going to get you there either. So you could see there was 6.6 to 30.5, and that was just looking at the first couple of days before feedback occurred. After feedback, the SICU increased faster and to date continues to have higher rates than the MICU. Still not quite sure what the dynamics are going on there. Is it a leadership issue? But they're close. I mean, one will be 90, the other one will be 87 or 88. But the SICU, even though it was the second unit, has not been doing it as long as the medical intensive care unit, was able to get it up faster and keep it up higher than the MICU. So in conclusion, third-party remote video auditing without feedback does not change the rates of hand hygiene. The data suggests that remote video auditing with feedback can increase hand hygiene, and that rates prior to and after feedback in the SICU were higher than the MICU, and we believe this is just a halo effect. And last, which we did not present here, and keep in mind I did mention that we ended up selecting a unit that had low rates of infection to begin with. We did look at infections. We did see a temporal decrease in methicillin-resistant aureus transmission within this unit, and there was significance. We also saw a decrease in C. diff within the unit, but that after a 2-year period of time was no longer significant, but we did see a downward trend. I feel what happened with the C. diff was with the cameras and people trying to adhere to the guidelines, they were removing their gloves, less contamination of the environment, which may have translated to decreased transmission in the unit. How am I doing on time? Am I right? Okay. All right, so that's our study that was presented. Like I said, we're going to continue to work with Adam, with some of these other applications. We realize the other applications are going to be a little bit more challenging because the patient will be in the camera view. So we're working on how to build those rules as well as, manage the legal piece of it. All right, so I'm going to end here. I don't know if Dr. Farber has any.
We'll open it up for any questions that people have. Ron in the back is walking around with a microphone, so if anybody just raise their hand. Ron, we've got somebody right up here.
Hi, my name is Siobhan Lyon, and I work at the Richard Wells Research Centre in the University of West London. Basically, I want to know how you're going to transfer this to the UK system where we use the 5 moments of hand hygiene, because it's much more complex than just hand hygiene entry and exit.
I didn't totally hear your question, but you're asking sort of the complexities of the UK system. How are we going to address those?
5 moments of hand hygiene.
Well, I think one thing I touched on earlier with regard to the open bay units, that to me seems to be the most major difference in terms of complexity, technical complexity, in the way that you guys monitor for hand hygiene today using the WHO guidelines. I think that the consent issues are not going to be much different than what we've seen in the U.S., but we'll have to see. The ethics piece, which is very similar to what we call in the United States the Institutional Review Board, that looks very similar. And the 2 trusts that we're working with now, they're dealing with all those same issues. Did you have any specific complexity you wanted to ask a question about?
Yeah, just with the 5 moments, it's not just washing your hands before you touch a patient, it's washing your hands again before you touch a susceptible site, like a central access site or a wound, and then washing your hands again after exposure to blood or body fluids. And then if there's any contact with the patient or the patient's environment, that's 2 more steps. I would just imagine you'd have to have somebody very well trained, like a nurse or physician, observing a patient continuously while they're in contact with a healthcare worker.
Yeah, so that's a good point. So one thing that I didn't mention is that in addition to having cameras right in on the patient beds, there are going to be cameras placed on every sink that might be a potential sink that would be used for hand hygiene. And so we're in those discussions right now with the trust around some of those secondary and tertiary rules. And some of it may be complex, so you might actually wind up having sort of 2 tiers of auditing that we do. One which would be sort of the majority of the audits, just the basic, coming into contact with the patient or leaving the patient. And then there are discussions around having a secondary set of audits that would be done by more, advanced or more trained auditors to look into more detail around the extra complexities. So I think the one important note is that these trials that we'll be doing here with the 2 trusts are very experimental. We don't have all the answers, and so we'll be back talking about this every few months for the foreseeable future. So we'll be sharing that information. Up here in the front.
Hi, Nagish Desai from King's College Hospital. My question is, if you're purging the data immediately after the video's been taken, how are you going to be able to identify individual staff members that are consistently failing?
So and there were some cases in the beginning with these guys. So it was all aggregate feedback, but there were some cases where a small number, and it's this way in almost every industry. You guys have a sort of an even easier setup than they do in the U.S., where they have, one nurse might handle patients in several rooms. What I'm seeing in the open bays, at least, is that there's typically one nurse for that shift assigned to a specific patient. So there might be other people coming and going, but there's primarily one person who's going to be doing the vast majority of the hand hygiene to begin with. So if there's somebody that's way off track, it'll be a known fact. It shouldn't take very long to identify the variance and address it. And that's a challenge that they have too. I think that part of the reasons that it's hard to get the scores up is they have lots of people, consultants coming and going. And I think if you look at the nurses, their scores are over 90%. So there is a group that's lower in the 70s, and it's the more transient workers. But thank you all very, very much. We appreciate the opportunity to present today.